Thank you, Michelle. Yes, you see the title which was given to me, and it's mainly around SGLT2 inhibitors. And I gave, of course, I have this transparency declaration, which we should always have, and this is with companies who produce SGLT2 and do large clinical trials. So I set out an introduction on science, trials, and real-world situation, how SGLT2 inhibitors are currently seen in the transplant field. Yeah. So SGLT2 and transplantation is the most frequent question I hear currently in webinars. Yeah. Can we use this drug? However, most doctors out there, their approach is, can we treat NODAT at the early post-transplant period? And most of them do not look at the long-term follow-up to prevent progression or kidney failure of the graft. So they do not look yet on glomerular decompression, what we can do with SGLT2 inhibitors. So these two areas need to be covered, and I'm actually in work group 1 with Bert and Alexander, and this is a question, what I have here, question number 11, and we can bring something out to you. By today, every transplant center has made experience with a handful of patients and have put them, let's call it off-label, on an SGLT2 inhibitor. And I think this group is growing as long as doctors do not experience any side effects. Currently, science is weak. We have case series only out there and one meta-analysis. The meta-analysis is 132 patients, which is available. So far, we have reported no severe adverse events, yes, no infection signals. But I know that there are investigator-initiated trials planned with 1,000 and more patients. But this trial 1 is coming from the Netherlands. They lump together dialysis, transplant, and low clearance people. So maybe the group of transplanted people will be around 300 to 400, and we will get more safety data, certainly in a number of years from now. But what about efficacy? Slowing the deterioration of kidney function, slope studies. I see only slope studies out there with a sample size of 100 maximum. I wonder whether we get here solid evidence in the next years. Other future management approaches currently are underway. You have seen in the US the non-steroidal mineralocorticoid receptor antagonist finerenone is already approved in type 2 diabetes with CKD and residual albuminuria. So actually the studies with non-diabetic chronic kidney disease are underway, but you can potentially think about retarding progression of a transplant also with finerenone or with a steroidal MRA. The non-steroidals finerenone look better in respect to the potassium. So actually there is also a niche there, and we may discuss this over the next months. The discussion is not yet out there, no question about these small remote people, patient groups, but we can have maybe one statement in the controversy. So we have a lot of research questions also on the table. I just outlined one here, which will be the most interesting for you. Can we use ESAs or the HIF stabilizer, or can they be abandoned when we introduce SGLT2 inhibitor treatment? Because you know that erythropoietin production is increased and the hematocrit goes up, both by volume contraction and by HIF stimulation. So actually, this is a very hot topic also, what the industry is looking with some nervous signs in the pre-dialysis area, but how can SGLT2 inhibitors help to improve the upcoming anemia. So lots to discuss. I just want to point out that there are the KDIGO 2022 guidelines on diabetes management in chronic kidney disease out for public review since a couple of days. So it's still controversial. No, you can download it already from the website, and the comment is open up to March 16. And you can look at this. And I extracted a practice point from these diabetes management guidelines, and they read, SGLT2 inhibitors have not been adequately studied in kidney transplant recipients who may benefit from treatment but are immunosuppressed and potentially at increased risk for infection. There is therefore the recommendation to use SGLT2 inhibitors does not apply. See recommendations 1 and 1.3.1 is supplemented with a research recommendation, studies to establish whether there are safety and clinical benefits of SGLT2 inhibitors for patients with type 2 diabetes who are kidney transplant recipients at high risk of graft loss, CVD, and infection. So there is a statement already out there or new in this 2022 update, just to remind you. This is also something new from the March public review. The pyramid is upgraded, and there is one recommendation in it recommending SGLT2 inhibitors down to an eGFR of 20. And this may be also of interest for transplant people. If you can start treatment above 20, and this is a 1A grading, very strong, the strongest we have. So most patients should receive this treatment, and this is a first-line drug treatment in diabetes. And when we have the non-diabetic study patients from EMPA kidney, and we have it already from DAPA-CKD, then I think KDIGO can also write in non-diabetic kidney disease, they recommend with 1A SGLT2 inhibitor. And this applies again to our transplant patients. So look at goal-directed therapy on the top. The MRAs and non-steroidals are already there, and they are recommended. No, they are suggested. You may see this guideline in full writing at the website. So the question is, do we need really a study in transplant? Yes, of course, we need the evidence. We need 5,000 transplanted people with a heart, cardiovascular, and kidney outcome. But if we look at the kidney outcomes in the studies with no diabetes, in brown and in blue with type 2 diabetes, we have these studies. And these are about 100,000 patients here in these trials, in randomized controlled trials already studied. And you look at the DAPA-HF is heart failure, EMPEROR reduced is heart failure, CKD is okay with DAPA. Then in blue, we have all heart failure, CKD, and cardiovascular outcome studies here in this table. But irrespective of the underlying pathophysiology, pathogenesis, or comorbidities, the point estimates are all left of unity. And this the drug has really taken us away when you look at the 40 to 50% relative risk reduction, what we even do not achieve with an ACE inhibitor today. So there is really a lot of evidence outside the transplanted field. And the question is, when we put an extrapolation now in writing, in this is really controversy then, and maybe worthwhile to think about this. So do we need really clinical benefit outcome studies in the light of the overwhelming benefit in CKD is something we can discuss here. I think I'm already coming to the end, but I can adjust one data set of a trial published in 2020. It's a meta-analysis, a systematic review, taking all the databases together. And here you see all these 8 trials we have until April 20 and 2 more could be added here meanwhile. But you see the participants on SGLT2 inhibitors. Come on, this is really low numbers. Yeah? So what can you do out of this? And this is short term, all lumped together. Yeah, this is the evidence we look at currently. And what this meta-analysis also outlined, the mean GFR was 64 of all these transplanted patients. So actually they looked really at hemoglobin A1C. And you can achieve a decline in hemoglobin A1C when you have a good GFR. But if you go further down to 45 or 40 ml per minute, you nearly have no glucose excretion and you have no hemoglobin A1C lowering. So we are going towards organ protection, prevention of failing graft. All other things are maintained. We have body weight, we have a decline in UACR and blood pressure, but this meta-analysis tells us that it's unchanged because the low number of patients accumulated do not lead to a significant value. So they call it unchanged. They do not have a lot of genital infections. In fact, there was only one. And the fear in all transplant centers across the world, I'm talking in webinars, the fear is going away that it impacts infection. Yeah? The UTIs usually are the same in the placebo as in the verum phase in the other studies. Yeah? So maybe the transplant people have no infection and risk for infection. And there was no ketoacidosis. So this was just this data set I have prepared for the background, more slides. These are all the data and trials. This goes to the work group. I will not talk about this. Look at these ongoing studies, 1, 2, 3 with N of 50, 70, 70. Ongoing studies 2, here 220 in Brazil. But the readout parameters are difficult. So this is not solid science, but it gives safety, maybe us a good feeling. And here is our question 11 from work group 1. I'm working together with Prabir, and but I think I stop here. He also has looked at it and brought some good ideas to the work group. So thank you for your attention.